Hello, today we'll deal with Clozapine as a very good treatment for schizophrenic patients that are resistant to normal antipsychotics. We have tried more than 2 trials of regular antipsychotics, and it has to be more than 6 weeks each. So we have tried one antipsychotic for more than 6 weeks, then we have switched it to another antipsychotic for 6 weeks, and despite having a very good adherence, that the patient took the medication more than 80% of the time, so more than 80% adherence, we have less than 20% symptom reduction. So the symptoms didn't really become better. They just dropped with around 20%. And one of these antipsychotics was also taken as an intramuscular injection, so not only oral tablet but intramuscular injection. I dealt with this whole thing in a video called Treatment Resistance, and there I dealt with something called the TRIP criteria. That is TRRIP criteria. That stands for Treatment Response and Resistance in Psychosis. This is a very, very good criteria when we want to define treatment resistance, because we are not allowed to give Clozapine until we know that the patient is having a treatment resistance, because Clozapine is our best solution when it comes to treatment resistance. The best antipsychotic against treatment resistance. And therefore, the question is then, why don't we start with Clozapine from the beginning? If it's so good, why don't we start with that? The reason is the side effects. Side effects are more with Clozapine, so we always start with other antipsychotics. And then, if we cannot achieve a very good result with others, then we choose Clozapine. And today we're dealing with the indications. Which are the indications of using Clozapine? First of all, treatment resistance. So you need this criteria fulfilled. If you reach all the points I listed in the other video, then you have the first rule finished. That meaning we have a patient with schizophrenia who is having a treatment resistance. That's the first point. The other point can be also if the patient is having suicidal thoughts. He wants to commit suicide, or he's harming himself, or he is harming others. Then we need to consider Clozapine, because obviously the treatment is not working. So suicide thoughts and so on. Then of course we have other criteria that needs to be fulfilled before we start Clozapine. So the indications are having a neutrophil count more than 1,500 cells per microliter. That meaning the neutrophils are our immune system cells. So this is the police force of the immune system. And if the count is less than 1,500, then you cannot really just start with Clozapine, because what can Clozapine have as a side effect? Dropping of leukocytes, so neutrophils, and all the other granulocytes that we have. So the immune system can be decreased with Clozapine, not for all patients, but in some. And if you already have a patient who has less than 1,500 neutrophils, then please don't start Clozapine. We need to define some rules when we can start them. We will deal with that in another video. So if you have fulfilled all these criteria now, then we start Clozapine. And Clozapine has to be written and understood by the doctor that is giving it. So not every doctor can give Clozapine. The pharmacy that is giving Clozapine also has to be educated on how this will be delivered to the patient. And then of course the family members needs to be educated, and the patient needs to be educated about the side effects of this medication, and how we should go along finding about the symptoms, and then how we treat it, and adherence, compliance, and everything needs to be discussed with the patient, because the benefits needs to outweigh the harm from this medication. And the benefits of Clozapine would be that the schizophrenia will be decreased. Schizophrenia in this disease is much more harmful for the patient. He can commit suicide, he can harm other people, he has psychosis, and he is dangerous to himself and to other people. And therefore, the benefit of Clozapine is much, much higher than the disadvantage of Clozapine. So, what we start with is, as we said, TRIP criteria, and we will then define if the patient is having a treatment resistant. Then we will check the neutrophil count. Then we will check all the other laboratory parameters that can be important. For example, the heart enzymes that we have, because the side effects of Clozapine can be myocarditis, for example. And we will deal with all the other side effects of this disease in another video. What I want to just highlight here is that you don't start Clozapine just like that. Okay, you don't give a tablet of Clozapine and then you're done. You need to fulfill some criteria. You make blood samples of the lipids of the patient, of the heart enzymes of the patient. You make an ECG. You make even a echocardiography. So you check all the parameters of the patient, the vital parameters, how large is the patient, how thick is the patient, and so on. So, and then after you have reached this and you have seen that the neutrophil count is more than 1,500, then you start with the trial of Clozapine. And the Clozapine will now be a 24-week trial, 24 weeks. So it's not a very short one here. We will have a very, very long treatment of clozapine, and the level of clozapine needs to be more than 350 nanogram per milliliter in the body. So around that level, and then we know that we have reached a good dose of clozapine. So 24 trials. Don't stop clozapine before that. Of course, if you have severe side effects, for example, many patients can have severe side effects, and we will deal with that in another video. Then you need to reduce the dose, of course. But don't stop clozapine. You never stop clozapine due to the symptoms. You just decrease the dose. Of course, if the patient was having a neutrophil count which was very low, and now suddenly the patient has almost no neutrophils, then you need to stop clozapine, because neutrophils are the police force, the immune system of your body, and that is a very important thing to always monitor. You monitor it very weekly, even in the beginning. You monitor all the parameters that I said weekly, and then you increase it until 2 weekly, or a monthly, and 3 months, and so on, and then 6 months, and so on. You increase the span of how long you can let the patient be alone. And of course, as we said, we had family members need to be educated about it. Not only the patient should know about this disease and should know about this medication, the family members or the people around the patient that is taking care of him. Because schizophrenic patients are usually not living alone, and they have to have some kind of social network, either family member or somebody who is in charge of his life, one can say. Okay, and then of course, aside of these trials, we will have non-pharmacological treatment options. That meaning not only medicine, not only medication can be given, so we can have non-pharmacological, and this is also cognitive behavioral therapy, meaning a psychiatrist or a psychoanalyst and so on can talk with the patient and have a cognitive behavioral therapy. Also, there is something called family therapy, family education. There can also be social skills training, that the patient learns how to live a life with schizophrenia, social skill learning, and so on. And if you have all this in mind, then you start with clozapine. Thank you very much for listening.